Inga mana, inga waka, inga reo, I rau rangatira mā. Thank you for joining us. Tēnā koutou, tēnā koutou, tēnā tātou katoa. So I feel incredibly proud to be standing here, not only representing the beautiful organisation that Cure Kids is, but also as I hold very dearly in my hand as a custodian for the support of the research, which will transform children's lives. And a very special welcome to the researchers that we have here today. Thank you so much. You make the vision for our tamariki come to life, and through you we stand on the shoulders of giants. I'd like to acknowledge one totara today. So Sir Bob Elliott. Now Sir Bob passed away this year, but his legacy in founding of Cure Kids almost 50 years ago was his proudest achievement, and he stood up in front of a huge audience when he was nominated for Senior New Zealander of the Year, and he said, founding Cure Kids was my greatest achievement. So, and today you'll very much see his vision come to life, and thank you, Sir Bob, for all of your inspiration, and I have nowhere to hide now because he's watching. So I just want to spend a little minute just talking about how this project came to fruition. And we have been funding some wonderful researchers in the rheumatic heart disease screening area, or in rheumatic heart disease and rheumatic fever area. But I had an enormous sense of frustration transferred from Bob that RHD and rheumatic fever is a completely preventable illness, and New Zealand has the most dire statistics. It's a third world problem, and we shouldn't have it. And that was catalysed this year when I saw the enormous response to COVID, and how, because it can affect anyone randomly in New Zealand, suddenly we have a massive call to action, and yet we've got this hideous disease that is generated from a point of social deprivation, and yet we haven't found the answers, we haven't found the preventions, the vaccines, the cures, the treatments yet. And so I went to our board with Sir Bob firmly burning a message in my ear, and I said, I think the best way to do this is to have a collaborative approach, throw all the researchers in the sandpit together so that they can all talk and collaborate and bounce off each other an idea for how do we solve this problem for once and for all. And I'm really proud to say that our board committed one of its largest funding grants of $3 million over 3 years towards this project. And that does keep me awake at night because we do have to find funding for it. But I was really proud that the board could back me for that, and knowing that Sir Bob was gravely ill, to be able to promise delivery on that before he passed away has a significant emotional attachment for me. So, but enough about that. We won't give up on the children that need our help. So thank you for all of those amazing researchers who are in the waka with us and the incredible support. And I would love to see our team of 5 million solve this incredibly entrenched disease that affects our most vulnerable. Huri noa I te whare Tenecotto katoa.
Kia ora, Francis. We'd now like to welcome Professor Michael Baker, who I think is well known to everybody in New Zealand now, maybe not so much for his work on rheumatic heart disease. So.
Well, tēnā koutou katoa, malo alele, talofa lava, kia orana, warm Pacific greetings to you all. And thanks, Francis, for the introduction. It's very good to be here at this event, which is really celebrating this Cure Kids remarkable initiative. And I'd also like to just say we're building on the legacy of, as well as Sir Bob, also Professor Diana Lennon, who died 2 years ago, and also Stuart Jessalyn from the Ministry of Health, who died last year. So they've all made a huge legacy that we're carrying on with. In many ways, it's shocking that we're even having this meeting now in 2020. I mean, as Francis has said, rheumatic fever and rheumatic heart disease are third world diseases, New Zealand and Australia have this strange distinction of being the only high income countries where these remain an important health problem. The second thing that is really stark and also equally shocking is the huge inequities. And I could present numerous graphs and data to point that out. Everyone in the room knows this. But one figure I think really does summarise this, and that is that by the time you get to the age of 20 in New Zealand, if you're a European child, you've got a 0.01% chance of having acquired acute rheumatic fever. That's 1 in 10,000. And if you apply that to New Zealand as a whole, that would mean we'd get 5 or 6 cases a year in New Zealand. We get, 180 cases that we know about, and there'll be additional cases we're not aware of. But if you look at the risk for a Maori child by the age of 20, it's 0.5%, so 50 times higher. And for a Pacific child, it's 1.2%, so 120 times higher risk of having ARF by the time you get to 20. And there's no other disease in New Zealand that has such stark inequalities. And while ARF itself, acute rheumatic fever, is a serious illness, it doesn't have on its own these long-term consequences. We know the real problem is that is putting those children down a pathway of having to live with rheumatic heart disease, a chronic disease that shortens lives and limits possibilities for these young people. So one of the positive things I think about working in this area, it's highly collaborative, and as you can see from the mix of projects, they really involve many of the people in the room on multiple projects. And it partly reflects the fact that combating rheumatic fever requires action at every stage, from looking at pure public health areas, primordial prevention, housing, through primary care, early diagnosis, and then treatment, secondary care in hospitals, and also tertiary care, rehabilitation and so on. And I think that reflects just the huge range of disciplines that are working in this area. And sometimes there's skepticism about research. People say, you always say more research is needed. This is very much a disease where that is true, because we actually do not have enough tools to prevent acute rheumatic fever and manage rheumatic heart disease in an optimal way. And that is why we actually do need more of the research that Cure Kids is funding. And even now, if we said, look, here's $50 million to use on interventions, we would still need to be thinking very hard about that, how that was applied, because our research base is still too small. So that's why I think this is such an important initiative. Certainly, I think elimination is probably the word of the year, and I think it is interesting if we could apply that. And the reason that New Zealand, I think, has achieved so much is we've had this joining together of science and political leadership. And we've achieved a huge amount. We've got the lowest COVID-19 mortality in the OECD, and a whole lot of other interesting benefits in terms of preventing respiratory illnesses and influenza. But just think, if we could apply that same science-based leadership, linking through to political leadership, how much we could achieve with this disease. And I think I really have to congratulate Cure Kids. This is fantastic that this initiative, this huge valued resource you're putting into this area, and I think that will give us a much better scientific base for moving ahead in this area. Thank you.
Thank you, Michael. I'd just like to tautoko what Michael said about the importance of evidence-based medicine. It's wonderful that the government has made some big announcements recently about putting funding towards healthy homes based on Professor Baker's research, and that is really important. But there are areas where we don't have clear evidence on what to do, and that's where we have remaining research questions. And Cure Kids is really happy to be able to meet some of those needs. So sorry, I should have introduced myself. My name's Tara Satyananda, and I'm Director of Research at Cure Kids. And I can tell you a little bit about the process that led to this. So with our founder, Professor Sir Bob Elliott, And with the vision of our Chief Executive, Francis, there was really an identified need that we had to work on rheumatic heart disease. We talked to all of the researchers in this area and put together a funding round for contestable funding. And we got a huge number of applications. We selected based on criteria that included scientific excellence and quality of the research design. They included the potential to really have an impact and make a difference on this disease with sort of practical solutions that would either improve care, help us understand the cause of rheumatic fever, or indeed to find a cure. The criteria included the calibre of the researchers, their track records, their background, and their inclusiveness, the extent to which the research teams actually included patients and communities and healthcare workers. We also looked at the criteria of Mātauranga Māori, where the researchers had considered thinking about Māori knowledge and Māori kaupapa and Māori tikanga in their research proposals. And so there was a very rigorous process, and we in the end selected 10, which went through a process of a further peer review and discussion, and in the end we whittled it down to just these 6 projects. So we're about to have some amazing presentations, and you'll see exactly why we selected these 6 people. So the first person I'd like to ask up is Dr. Jessalyn Lowe, who will talk about her team's work towards a vaccine to address the problem of rheumatic fever and rheumatic heart disease. Thank you, Jessalyn.
Tēnā katoa. My name's Jessalyn, and thank you for the introduction, Tara, and thank you to Kia Kids for having me here today. Excuse me. So my research focus is on disease prevention through the development of a vaccine. And this here gives you an overview of how rheumatic heart disease develops. And what we know currently is that it is preceded by a strep A infection. Typically, this is a relatively mild infection, such as strep throat, but what can occur in at-risk individuals is that an inappropriate immune response develops, and this leads to the far more serious condition, acute rheumatic fever. What happens with repeated infections and recurrent episodes of acute rheumatic fever is the permanent damage to the heart that we see in rheumatic heart disease. So where my project fits in is right at the initial stages. So by developing a vaccine that can prevent the initiating or triggering infection, we should be able to prevent any downstream disease. So the vaccine target is a protein called the T antigen. And you can see these little dots here. These are the T antigen, which forms what we call the strep A pilus. What a pilus does, are these kind of hair-like protrusions from the surface of the bacteria, and they help the bacteria to attach to the lining of your throat, for example, in order for it to initiate an infection. You can think of the pilus as Spider-Man's sticky web, being able to grab on and take hold. So we have already produced this vaccine called T-Vax, and it incorporates 18 different T antigens. And this comes from both New Zealand and globally relevant strains, and we've done this in order to ensure we get broad coverage with our vaccine. We have shown protection in animal models of disease with this vaccine. However, the level of protection is not good enough yet, and improving this is the focus of the Cure Kids funded project. To do this, we have partnered with a few researchers, both in New Zealand and internationally, to look at new ways of boosting the immune response to our vaccine. And this has come from some various sources. There are some immune-boosting compounds that are found in shark oil, for example, even some from marine sponges, and also techniques to package our vaccine in nanoparticles. The aim, of course, is to ultimately to boost the immune response to our vaccine and make sure our vaccine is effective to move forward to the clinic, and also to gain a better understanding of what is required for protection against disease. And with that, I'd just like to thank the large number of people and funding that we have received for this work so far, and thank you.
Thank you so much, Jessalyn. I'd now like to call on Dr. Nikki Morland, who's working on a better diagnostic treatment.
Kia ora, and thank you very much for Cure Kids for organising this event and the funding. So that's slightly disconcerting to see a photo of yourself that's larger than your own head. Right, so this is looking quite familiar now because Jace has just shown this. But what I really want to point out is this inappropriate immune response here. So we know that rheumatic fever starts with a strep throat infection. What we really don't understand very well is then what goes wrong in some children. That means they don't just clear the infection, they go on and they develop this autoimmune or autoinflammatory-like condition that we know is rheumatic fever. And the thing that we're most concerned about in rheumatic fever is carditis or heart valve, heart inflammation, because that is the thing that can lead to long-term heart damage and rheumatic heart disease. So one way that we can think about reducing rheumatic heart disease, in particular that serious long-term consequence of rheumatic fever, is improving the diagnosis of rheumatic fever. So at the moment, there's a clinical diagnosis. It's all clinical signs and symptoms, and all children need a heart scan to get a definite diagnosis of rheumatic fever. There is no one specific diagnostic test that can be done to diagnose a child with rheumatic fever. And so that means that diagnosis can sometimes be delayed or in fact can be missed. And certainly in settings overseas, up to 80% of children present with rheumatic heart disease where their prior rheumatic fever has not been diagnosed. And we know that misdiagnoses also happen here in New Zealand. And so our work is really focused on trying to improve the diagnosis through using cutting-edge scientific techniques to find markers that could be used to improve this diagnostics. And so we're doing this by looking at this pathway of disease, and in particular, this part of the pathway, this part that we don't understand very well at all, which is how does the body go from having a strep infection to then this inappropriate immune response? Something goes wrong. And so if we study this part of the pathway, we hope that we can identify new markers that can then help with diagnosing rheumatic fever early and fast so that we can stop this progression to rheumatic heart disease. And so that's exactly what we've been doing. So we're looking specifically at this part of the pathway, and for our work we're focusing on antibodies. So antibodies are these immune molecules that circulate in our blood, and we know that in rheumatic fever antibodies have a really significant role in causing the disease. And we've known that for a very, very long time. So this is an image that was taken right back in the 1960s, and it's a mitral valve that came out of a child that had rheumatic heart disease. And you can see that that mitral valve, all of these white bits of colour that you can see on the valve, that's staining for antibodies. And so this valve is completely coated in antibody, and that antibody shouldn't be there. right? So a heart valve is not normally coated in antibodies. So what that tells us is the antibodies that were part of the immune response for the strep infection are somehow now behaving in a way that they shouldn't, and they've ended up being in a place where they shouldn't. And so what we are focused on doing is profiling the antibodies, or understanding the antibodies that are there in children with rheumatic fever, to help understand what's gone wrong in the disease, what the dysregulation is, but also to help identify new biomarkers that can help improve diagnosis. And so we've called this Understanding the Rheumatic Fever Antibodyome, and so that means what we want to do is we want to probe every aspect of antibodies in rheumatic fever. And we can do that because we've been working with a group of really amazing people for a few years now, public health, clinical, our Māori and Pacific partners. And so what we have been able to do is get together a really good collection of samples from children that have had rheumatic fever, from healthy children, and from children that have just had strep infections. So they've had those strep throats and those strep skin infections. And what we are now able to do in the laboratory is apply a whole lot of different contemporary lab techniques to those samples to look at what antibodies look like in children that have had rheumatic fever, for specific markers, for specific types of antibodies that are not present in healthy children and not present in children who have just cleared a regular strep infection. And the hope is that they will become diagnostic markers for the disease. And of course, in the process, what we're also trying to do is understand that dysregulation more. And we're working, as I said, we continue working with a great group of clinicians and public health, and also we've got some really excellent international partners on board to help us with this cutting edge science so that we can apply the best tools possible. Thank you.
Thank you, Nikki. I think I did you a disservice by saying that you're just developing a diagnostic test. I know that the immune dysregulation and all of the complex interacting factors make this a hugely complex disease, and that's why there are still outstanding research questions. So the next person who's been working on this is Dr. Julie Bennett, and she's working on another method for secondary prophylaxis. Thank you, Julie.
Tēnā koutou katoa. So I'm going to give a very quick overview of the SCIP Rheumatic Heart Disease Project. So firstly, I'd just like to acknowledge that I'm speaking on behalf of a group, and this is a trans-Tasman collaboration. So for around 70 years now, the only proven way to prevent rheumatic fever progression has been through penicillin. And this has tended to be administered through a deep intramuscular injection into the backside. And from my understanding, this can be extremely painful, and it needs to be delivered every month for often a period of around 10 years. So what this project is doing is looking at, can we deliver penicillin in a different way? So this is the device that we're going to be trialling, and at the end here there is a catheter which will be inserted just under the skin on the stomach in the subcutaneous layer. And then the penicillin will be in it, and it will be infused over a period of about 30 to 60 minutes. So there's been some background work to this, a randomised control crossover trial that looked at the difference of how long penicillin can be in the blood when you're comparing injection to the infusion. So this is the ideal concentration of penicillin that we want in the blood. And they've looked at absorption to work out what dose we're going to need to be giving. So this is when you inject, you can see it drops down just after 30 days. This is with a high dose, so this is giving a dose of around 8 times the normal amount of penicillin in the injection. And this is with the subcutaneous infusion. So from this we can see that the subcutaneous infusion lasts a lot longer. So we're hoping it to last around 3 months rather than 1 month. So this is a multi-phase trial. Phase 1 and Phase 2 are both looking at the safety how painful it is, and we're also measuring the penicillin levels in the blood. The first phase will happen in Perth, and we're looking at 24 healthy adults, and half of those adults we're going to want to have a BMI that puts them into obese or overweight, because different sized people absorb things differently. If that all goes well, then we'll move into phase 2. Phase 2 will happen in Wellington, and we'll be recruiting 40 young adults and children who are already receiving the intramuscular injections. So this is how it will happen. We'll have a recruitment phase, and then everyone who's in the study will need to come in and be monitored for 12 hours. They'll have the subcutaneous catheter put in under an ultrasound to make sure it's in the right place, and then they'll have the high dose of penicillin infused over 30 to 60 minutes. Then over the next 12 hours they'll be monitored. We'll be taking blood samples from the finger so we can measure the penicillin, and we'll be looking at any adverse complications, any skin irritations, any redness, any pain. And if everything looks good after the first 12 hours, they'll be allowed to go home, and after that we'll be monitoring them for the next 112 days, where we'll be asking the same thing about have they got any pain or redness or discolorations, and we'll be continuing to take regular finger prick tests of the blood to monitor for the penicillin to see how long it's lasting in the blood. We're also going to be doing some interviews, so we're going to be interviewing the people who are getting the infusion and who are on the intramuscular injections to see what their experiences are and how it works for them, and their whānaus as well. And we'll also be interviewing healthcare workers who are administering the infusion and the injections to see how it works for them and what their perceptions are and how it worked for the patients. So at the end, we would hope that we will have a delivery system that can deliver penicillin for a longer period of time, so 3 months rather than 1 month, and we're hoping that it will be less painful to deliver. We're hoping with this, then we'll have improved adherence, and with improved adherence to the penicillin, we're hoping we'll have less disease progression, so less people going from rheumatic fever onto rheumatic heart disease. I'd really like to say a big thank you to Cure Kids for funding this, and for also funding all the other wonderful rheumatic fever and rheumatic heart disease projects here today.
Thank you, Julie. So next up, we have a project that is going to be represented by Dr. Annika Anderson and Dr. Rachel Brown, and I believe they've got a number of members of their team here today, or just Dr. Anderson, but Shannon Luli is here as well. And this project is really focusing on the delivery of those injections of penicillin, particularly for rangatahi Māori and Pacific, to make sure that they're keeping up those regular injections, which will prevent further recurrent episodes of rheumatic fever and therefore hopefully prevent the rheumatic heart disease. So thank you, Annika.
Thanks, Tara. Ngā mihi o te ata kia koutou. Good morning, everyone. It's a pleasure to be here. Just shout out to my two colleagues there, Matua Shannon Leilua, who is our expert patient advisor on the project, and Dr. Rachel Brown, the co-PI of the project. I drew the short straw over breakfast, and so here I am, aroha mai, for that. Also like to acknowledge that Julie Bennett is also part of our team. It's a collaborative project that involves PHOs, 2 different universities and Counties Manukau Health. So we're also working with Dr. Pip Anderson, Dr. Rachel Webb, Belinda Paku, and Dr. Malakai Whanua and Dr. Rawari Jansen. So big, mostly Māori and Pacific team, and we're really excited to be here. So why are we doing this research? As Michael aptly described this morning, when we look at rheumatic fever, rheumatic heart disease, we see that it's almost exclusively a disease of Māori and Pacific. And yes, we can put that down to deprivation and colonisation, but as a Māori academic, I'd also put it down to privileging. And I think when we look at New Zealand society and the healthcare system, we're seeing a society that privileges non-Māori and privileges non-Pacific. And that's a huge driver for us as researchers to go, how do we flip the coin and how do we prioritise Māori and Pacific voices and experiences to change things as they are at the moment? To do that, we need voice and agency of Māori and Pacific patients and whānau. So this project is going to be working with rangatahi or Māori and Pacific youth. They're going to be driving the waka. They're going to be our governance advisory group, and they're also going to be our participants. So we've got the skills to do the research, but they are driving it and informing it so that we can make change. One of the reasons we're focusing on rangatahi is that rheumatic fever is a disease of youth. And within the current delivery process, which was really well described by Julie with the benzathine penicillin, we see that there's huge gaps in service delivery. It can work quite well at a paediatric level, it can work quite well at an adult level, but there's no rangatahi service. There's often no transition to care. There's a huge gap and we want to fill that. We also know that there's systemic racism throughout the healthcare system, and that's a huge barrier to many of our rangatahi. And on top of that, we have all the gaps that we see from deprivation about accessing and maintaining care for health. So this project is going to assess all of those and deliver an equitable model of care with a rangatahi focus, looking at bacillin delivery to prevent further episodes of rheumatic fever and rheumatic heart disease. So this is going to be a kaupapa Māori and kaupapa Pacific informed research project using mātauranga Māori and Pacific methodologies. As I said, it's patient, rangatahi patient and whānau centred, not only centred but led. And Matua Shannon there has got rheumatic heart disease himself and is at the helm of the waka driving it. We're collaborative and multidisciplinary, so we have social scientists, we have clinicians, we have epidemiologists on board within the team to provide those skills to make everything happen. And it's going to be quite a basic 3-phase model. So we're going to be triangulating data, drawing on research we've done previously with rangatahi, tamariki, Māori and Pacific, knowing the key barriers that they've experienced and what's made their journey better. We're going to be re-interviewing rangatahi within counties Manukau, just to make sure that we've got their whakaaro on board for what a model of health will look like, along with healthcare professionals in the area, developing a model of healthcare for bacillin delivery, piloting that in counties Manukau Health, and then evaluating that to see how effective it is. Our hope is if we get it right here in counties, which is the epicentre for rheumatic fever in Aotearoa, we can generalise that nationally. Oops. So the impacts, as I said, is hopefully we will bridge the gaps for rangatahi and we'll get rid of the ageism that exists. By making this a culturally responsive and equity-focused project, we'll also hopefully plug the gaps for racism, re-privileged Māori and Pacific, and address all these access barriers. I'd like to acknowledge my team and also say thank you to Cure Kids for this opportunity, and thanks to the rest of my rheumatic fever colleagues out there, because it's been a hard area to do research in with little funding, and I know that we do it all out of a passion for our tamariki, so thanks to all of you. Kia ora mai tātou.
Kia ora, thank you Annika. And so I think you can see some of the passion that goes into these projects. Next up is another amazing researcher who's helping to develop some of those tools that can be used to help make it easier for those young people to get their regular prophylactic treatments. So Dr. Diane Seka-Pautonu is doing research to develop another easier method for injections.
Malo lele, talo falava, kia orana, nisa bolavinaka, kia ora. Warm Pacific greetings to you all. O kuhingoa ko Diana Seka-Pautonu ko haume Aotearoa, New Zealand. O ku tamai mo ku whae o ku haume hapai mo vavao I tonga. Tēnā koutou katoa. So firstly, would just like to say thank you very much for the kind invitation to be here with you all today. Thank you especially to Cure Kids for supporting us with the work, and also for giving us an opportunity to share with you all about some of the research efforts that we have been trying to undertake and now can do with Cure Kids support. So just also wanted to acknowledge my colleagues who've spoken before me and will be speaking also, and friends in the room, and of course the Cure Kids whānau and the media who are here today. Thank you for making time to come along. So just with regards to acute rheumatic fever and rheumatic heart disease, so we've already heard about how we have overrepresentation in our Māori and our Pacifica children and our young people here in Aotearoa, New Zealand, and you've seen a couple of schematics describing the driver being a Group A strep infection of the throat and sometimes the skin, which if left untreated can trigger acute rheumatic fever, or that overreaction, that autoimmune response that our bodies can make sometimes in response to the gas infection. And if that's left untreated, we've been shown how that too can turn into something way more dangerous known as rheumatic heart disease. And it's the rheumatic heart disease, of course, that remains a significant cause of morbidity and mortality worldwide. And sadly, more than 75% of the world's children live in countries where rheumatic heart disease is actually endemic. And so while we're waiting for our Group A strep vaccine that Jessalyn is working very hard on, the next best recommended preventative is the monthly injections with a type of penicillin known as benzathine penicillin G. And if we find my slides, I have a molecular structure. Oh, awesome. Sounds like they're coming. I have a molecular structure to show you what penicillin looks like to chemists. And I might just move on to that. Now, Team Malo, thank you very, very much. I might just backtrack if that's okay, because it's really important to acknowledge that I'm not a lone ranger in this space, and that there are a lot of people and organisations who have supported us in this work. As many of you will understand, it's really hard to get funding, and Cure Kids have come along at a really critical time for us. So again, just wanted to acknowledge that, and also all of the various teams, organisations and people who are represented here. So you're all experts now. A Group A strep infection of the skin or throat, if left untreated, can in some people trigger acute rheumatic fever. And if that's left untreated or repeated severe episodes occur, that can turn into rheumatic heart disease or the permanent cardiac problems that can occur. Not everyone who gets a Group A strep infection ends up with acute rheumatic fever. Not everyone who gets acute rheumatic fever ends up with rheumatic heart disease. So in other words, there's still a lot that we don't know, and we still don't quite understand why it is that for us, as for Pacifica communities, that our children and our within our Māori communities, our children seem to have high rates. So still a lot of work to be done, but we are getting there. And so this is just to help emphasise the inequities that we see with acute rheumatic fever here in Aotearoa, New Zealand, where you can see that top line are the rates over time for Pacifica children and young people, the red line for our Māori children and young people, and our blue for our non-Pacifica, non-Māori young people. In terms of rheumatic heart disease, everywhere you can see a blue dot on this map is where we have rheumatic heart disease. And sadly, you can see a lot of blue dots on this map. And in particular, you can see in New Zealand and in Australia, where we are two developed nations, and we still have rheumatic heart disease. You can also see that there are a lot of blue dots in the Pacific region as well. So it's an issue there also. So here was the molecular structure that I had promised, and again, thank you to the IT team for making sure this was here. So this is what penicillin looks like to chemists. So it's made up of 2 parts of penicillin over there on the right, and 1 part of something known as benzathine. So it's the penicillin G bit that takes care of the bacteria and destroys the Group A strep bacteria, but the benzathine component is added to the drug to slow down the absorption so that we get a longer lasting penicillin. And the reason it's given intramuscularly in the upper thigh buttock area is so that we can get it lasting a little bit longer than it might do if you take the oral form. If you take it orally, it doesn't last as long, which is why you've got to take 2-3 doses throughout the day. So even though the penicillin works really well, there are some issues with it, and you've all heard that word pain. So these injections are pretty nasty. It's a very uncomfortable way to be receiving penicillin, and so it's a very deep injection, an intramuscular injection into the buttock area. And as you can imagine, our kids and our young people hate the injections, which is understandable. And back in the 1950s, which is the time where some first experimental research work was undertaken to look at how this injectable penicillin could work to try and prevent rheumatic fever and rheumatic heart disease. This was carried out in groups of soldiers, so military men, fit and healthy, aged between 18 and 24. None of them had rheumatic fever, and the results that came from those research works were very much needed at the time. But as you can imagine, we now have the means and the ability to look at how penicillin works for other population groups, and in particular within children and young people who actually have rheumatic fever and who have to use the drug a lot. So just a bit of background to how we got penicillin and why we use it the way we do today. Essentially, the results from those studies in the 1950s were extrapolated, so they were extended out a bit, and determine how we still give penicillin today in 2020 for rheumatic fever prevention. So I hope I've convinced you that we're at a point where we can do something better, and we should, for our children and for our young people. So the work that Cure Kids is helping us to do is to start actually making some of the different chemical forms of penicillin that are better suited for preventing rheumatic fever and rheumatic heart disease. And I should have added that those monthly injections is called secondary prophylaxis, so that's why you can see that wording in my slides here. And I just wanted to highlight that the way in which we've gone about this drug design process has been quite novel. So the novel part of it is that we've chosen and we've elected to be more inclusive of our communities in the drug design process. So in particular, our Māori and our Pacifica communities and other community groups who are represented with rheumatic fever and rheumatic heart disease in Aotearoa, New Zealand. So in other words, we've actually gone to them, we've gone to our communities, and we've asked them to help us design a new penicillin to prevent rheumatic fever and rheumatic heart disease. So what Cure Kids has done is help us build on that work that our communities have helped us to undertake, and to extend this further, where we are now at a point where we have enough information to start doing some of the early laboratory work to make these new penicillin forms. So just wanted to highlight some of the team members, and again, that I'm not doing this work alone, but that I have some wonderful collaborators, and just wanted to highlight here in the top left-hand corner in particular Dr. Philip Rendell from the Ferrier Institute. So we're working very closely with him on this, and of course with the team here. You'll notice in the top right-hand corner that some of our Pacific our clinical and health leaders from the Pacific region are also helping us with this work. So again, we are working in collaboration and inclusively with our Pacifica and with our Māori partners. And of course here we have Rane Winera Parai, just here in the second picture, and she's been a very staunch supporter of the work that we've been doing here, so really grateful to her for her efforts. And so just wanted to highlight that in order to get to this point, we needed to start also by looking at the pharmacokinetics of this type of penicillin for rheumatic fever prevention. So we've also led a pharmacokinetics study here in New Zealand, and it took a little while to actually get funding to do that. So in other words, we could have done this a little while back, but grateful nevertheless to eventually be able to progress this. And this is work in collaboration with our Trans-Tasman partners over in Australia and in the US as well. And this is the study that I also wanted to just highlight, which has provided some valuable information to us from our Pacifica and our Māori communities in particular, where we went to them to ask for their help in designing a new penicillin. Don't get me wrong, we knew that we all know there's an issue with pain with these injections, but we couldn't guarantee that we could make something new that would be completely pain-free. So, nevertheless, we asked for input from our communities, and they were pretty clear with us, and they shared with us and told us what they would want, and they have helped us be able to rank the drug characteristics from least preferred to most preferred based on their input. And we spoke to children and young people who get the injection, we spoke to their family members, and we also spoke to health professionals who give the injections. So we got a wide range of perspectives around this. So again, just trying to highlight that this is a very novel way of going about drug design, but nevertheless it's one that is more inclusive and ensures that, out of respect for our communities and the people who will be using a new penicillin, that they have had an opportunity to work with the researchers and to be part of this as well in a meaningful way. And last but not least, not forgetting our little ones as well. So have had the opportunity to go out and do some outreach work as well. So I love doing this, and there are others as well who I know do this, take time to go out to schools, to high schools, to other groups, to share a bit about the work that we've been doing, and in particular talk about the need for a new penicillin for rheumatic fever, rheumatic heart disease prevention in Aotearoa, New Zealand. So, malo aupito, thank you very much for listening. I'm grateful for your time. Gihi eiki o tua malo. Thank you.
Malo apito, Diane. And last but not least, we have someone who, like Michael Baker, like Denny Lennon, like Stuart Jessalyn, has really devoted plenty of time over his career to solving this problem of rheumatic heart disease, Associate Professor Nigel Wilson. Actually, while he's coming up, I might also say that Cure Kids is having a year of rheumatic heart disease. We're also investing in rheumatic heart disease in Fiji, and Nigel Wilson is also separately working on one of our projects in Fiji. Thank you, Nigel.
Kia ora koutou. This has been a slow train coming. So it's actually 20 years since the last international treatment trial for acute rheumatic fever. And so we tried in the late 1990s. Leslie Voss and I were junior researchers, and we tried intravenous immunoglobulin, and it didn't alter the severity of carditis after the treatment, at 6 months after the treatment. And of course it's the carditis, which is the inflammation of acute rheumatic fever. It's the severity of that at the end of your episode of acute rheumatic fever that determines the severity of chronic rheumatic heart disease. So obviously New Zealand's been trying to prevent rheumatic fever, and I guess as I've got older, we've actually now found there is another potential immunomodulator, and this was from work by the Australians published in 2018 about hydroxychloroquine, that it seemed to help in the test tube at least to switch off the dysregulated T helper cells. We've heard this morning how complex the pathogenesis of acute rheumatic fever is. And so in 2019 we had 2 children, one in particular came to us at Starship who'd had the most terrible acute rheumatic fever with inflamed mitral and aortic valves with severe disease. His heart was very stretched, already meeting the requirement to protect the heart by cardiac surgery. But he had shoulder pain, chest pain, and we used corticosteroids, and that dampened down the symptoms. And then we withdrew the corticosteroids, and back came the pain. The traditional ESR and CRP, the inflammatory markers, went up again. So after the third time of the steroids, we went to the family and said, look, there's this potential hydroxychloroquine. Would you like to try it? And the whānau said, yes, we would. And we backed off the third course of corticosteroids, and the hydroxychloroquine continued, and everything settled down. And at cardiac surgery, those veins, the valves were no longer inflamed. So, and then we had another child who started off with a classical acute rheumatic fever, who then got progressive carditis over a month. And again, hydroxychloroquine seemed to dampen things down. So, slow train coming. 18 months later, we are now ready, thank you very much, Cure Kids, to start an observational trial. And those are the collaborators there. And just, there's 4 hospitals involved in the Auckland region. And you can see there the variety of specialties involved because it's such a complex illness, acute rheumatic fever. And so we're ready now with an observational trial for feasibility, acceptability and safety. With probably 25 to 30 patients hope to be enrolled in the next 12 months. That pesky virus actually was helpful because people that will have heard that hydroxychloroquine was given for people with COVID, but researchers were rushing into this with huge doses, 2 to 3 times the established anti-inflammatory dose. The established anti-inflammatory dose is actually quite safe. It's been given a long-term in children and adults with chronic inflammatory disease like systemic lupus erythematosus. But we've got a data safety monitoring board. We have to look very carefully that there's no unwanted side effects, and that's a big part of this project. But excitingly, obviously the holy grail of any treatment trial is a randomized controlled trial. And just recently, Dr. Rachel Webb has got the first round from the HRC and EOI, so maybe in 2022, as long as we find that there's no bad signals from hydroxychloroquine in the acute rheumatic fever setting, then we can go on, and we've got plans with Australia to do an international RCT, and obviously that's the holy grail. So thank you very much, Cure Kids. This is very exciting. The disease burden, if this can dampen down acute rheumatic fever and reduce carditis, this will be huge internationally and of course in Aotearoa. Thank you.
Thank you, Nigel. The year of hydroxychloroquine maybe. So next I'd like to invite up, I think we have Matt Johnson here. Thank you very much for coming along. And also Francis is going to come up. So just to talk about a lived experience of rheumatic heart disease.
You did it.
No slides for me.
Just a picture of you.
Cool. Kia orana. Thank you, Cure Kids, for having me along. Sorry in advance for the loud tick. That's just the heart, it's a bit loud, just studying. But my journey started when I was 13, diagnosed with rheumatic fever. Did not know what it was, what it can do, and as a 13-year-old, I was told that I needed heart surgery, and it was quite daunting as a young kid, and obviously Mum felt it more than I did. She felt like she was responsible, and obviously she didn't know, and we weren't aware, but it was tough going through that. And obviously I enjoyed playing rugby, and I was told that I couldn't play rugby anymore after that, which was, I think I was more sad about that than actually going in for heart surgery. But being stubborn, I lived on the edge, and I pushed myself and obviously tested the medical staff, and they finally gave me clearance to play after a year. And so I did that. I was living my dream, 10 years playing professional rugby. Long story short, came to 2018. I finally made the Blues. I was living the dream. That was my dream job. And then again another setback. The tissue valve, aortic valve, started leaking again, enlarged, and I survived pre-season. So I did all that, and then came to actual season, and then the cardiologist said that I needed to go under the knife again, and I was just like, oh, here we go again. Like, you know, I finally made it, and then another setback. But again, I was stubborn. 4.5 months later, after heart surgery, I was back playing again. I was real stubborn, and obviously mum and all that, they're always worried, but they backed me, and they enjoyed that I was, you know, living the dream, enjoying myself playing. And then 2 years after that, I was in a meeting, sitting down, and I felt tight, sore, achy, but I was just sitting down, and I thought maybe it's just tight back after training and whatnot, and then I went to hospital and found out it was just a minor heart attack, and after all the tests and whatnot, and they found out my coronary artery was 85% blocked for 2 years, and I was playing professional rugby during that time, and they were surprised that I didn't, you know, drop while training or playing, and I felt it when I was just in a meeting, sitting down. So I'm quite grateful that I survived that. So that was earlier in March this year, and then I got studying, and then I got a stent put in because while it was blocked, it was tissue. It was tissue from the previous heart surgery. It wasn't plaque. So I think it was quite new to them, and they wanted to test out if a stent could go in there and fix it. And they did that, and it was still probably 30% blocked from what they told me, which was better than 85. So I still carried on playing. And then a few months later came June. I started aching again, just training normally, nothing out of the ordinary, nothing I'm not used to. I started training, started getting aches, chills, fever, and I thought maybe I got the virus, COVID-19. So I went in for a test and clear. Then I was in hospital for 2 weeks before they found out it was endocarditis. So a bacteria that was latched to my valve. And then I was like, here we go again, another setback. And then they said I needed surgery. I had to remove that. And they told me, I think 4 days before surgery, do you want a tissue valve or mechanical valve again? This was going to be my third one. And again, being stubborn, not, you know, caring about my health too much. I was like, I want a tissue valve again. Carry on playing rugby. So I'll go through the process. I've done it before. Hopefully I can do it again. Went under the knife and it was bad. Apparently that stent was lodged into the heart, stabbing the heart. I was so weak. The heart was so weak, impaired. I was in induced coma for 6 days. I woke up the following, I think, Sunday. I had surgery on that Tuesday. And I woke up and obviously they had to put a mechanical one in because they thought I wouldn't survive if I went under the knife again. So thankful for that surgeon making that choice for me. And yeah, I woke up thinking it was the same day. Just overnight slept, but no, it was major. And my family went through it, my fiance, so I think it was harder for them than it was for me. And when you're waking up to that, hearing the news and stuff, they were worried about telling me that I can't play rugby anymore, got a mechanical valve, and all that. But did not care. I was grateful that I was still there. I was still alive. They said that it was 50-50 during that time. So I'm grateful I'm still here. So yeah, we're organising a wedding instead of a funeral. So that's a plus for us. But yeah, I love the work that you guys are doing. Researchers Cure Kids. Obviously it's close to my heart, and something I do not wish on anyone, especially young PR Māori kids. Like they love their sports and whatnot, and it just holds them back. And it's not fun, growing up having heart surgery. It's scary. but yeah, now I'm known as the heart guy instead of the rugby guy, and I guess I'm grateful that I have a platform where I can, share, spread awareness and prevention, and I'll keep working alongside other organisations, and just sharing my story, and also connecting with the young kids. And I'm not sure if I can promote, you can keep playing rugby. I'm not sure if I want to do that, but yeah, that's my story, and thanks for having me.
Matt, if I can call you back actually and ask you to sit on the chair at the end, and we'll get some other stubborn and determined people up here to join you. So if I could ask for all of our guest speakers to come back up again, starting with Professor Baker here at the end, and then going in order of the speakers. So then Jessalyn and Nikki and Julie, Annika, Diane and Nigel. Thank you. So I remember when Nikki once came and spoke to all the Cure Kids staff, just keeping us all revved up and motivated and inspired. And Nikki described rheumatic heart disease as a university of diseases because it's so complex, it needs researchers from across the range of disciplines, all to put their very best thinking caps on to solve it. And I think the team has talked about some of the international collaborations and the ways in which they're working outside of New Zealand. So can I ask the panel, now that you're all up here, can I ask about why you think that this disease is so complicated and why it has resisted so many efforts of so many smart people over the years? You're all mic'd up.
I can start, if you like, from I guess a science perspective. I can't think of another disease where we have an infectious disease with the strep infection that then turns into an autoimmune condition with the acute rheumatic fever stage. So then we have to think about autoimmune responses. And then finally, with rheumatic heart disease, we actually have a chronic condition, a lifelong condition. And so in the one disease pathway, we go from an infection to an autoimmune disease to a chronic condition, and that's really challenging to understand. And so that's how it did get that name, the University of Diseases. If you understand every part of the rheumatic fever pathway, you kind of have a picture of all disease.
I agree, Nikki. I think the etiology is complex, but I think from a social science perspective, we've also got intersectionality of marginalisation. So we've got Māori, we've got Pacific, we've got deprivation, and then we've got children. And I think if we were talking, and I hate to say it, but if we were talking about Pākehā children dying at this rate, there would have been solutions put in place long ago. But I think because of those intersecting levels of marginalisation, it's been quite low on the agenda. And to unpack it, you've got to unpack what creates deprivation, what creates racism, what creates ageism, and those are really big questions and difficult to tackle.
Actually, some of the work we're funding in Fiji, Nigel Wilson's part of that work, but also Joe Cardo, who came up on the screen at some point, and also Professor Stephen Howie from the University of Auckland. That's looking at access to care, barriers to care, how to make sure that patients can get the treatment they need. The other thing about rheumatic heart disease is that the people on the stage are, cutting edge internationally. I think if you were to look at the top researchers around the world, some of them sit in Australia, some of them sit here, and some of them sit in the Pacific Islands. So we really are lucky to be able to fund some of the best here. Can I ask about some of the most important collaborations which you think have enriched your research?
I have a number of collaborations, as I'm sure my colleagues here have as well. I'm just thinking in particular of Pacific partners in the region. Sorry about that, don't know where that came from. But just with regards to ensuring that they too are included in this work, there are really high rates of acute rheumatic fever and rheumatic heart disease in the region. And over the and of course, many of you will be aware that our Pacific populations here in New Zealand are very transient. So we to and fro, but well, pre-COVID, we were toing and froing between the Pacific region and here in New Zealand. So ensuring that they too are part of the collaborations and the research efforts that we're undertaking is actually quite key as well, given that we have such high rates in New Zealand. So there are lots of other collaborations I could talk about, but that's one that just sort of stands out. But I'm sure those around me would like to add as well.
Certainly, we have a lot of collaborations with Australia, because Australia, the Aboriginal people there, also suffer very high rates of rheumatic heart disease. So, yeah, it's fantastic to work with the Trans-Tasman collaborations also.
Are there any questions from the floor?
Nodding sagely. Almost all of you have mentioned how difficult it is to get funding, right? So you're here, you're thinking Cure Kids, getting funding. Yet earlier this year, the Ministry of Health has said the disease remains a focus, though they've got no current targets. Call me cynical, but is it a focus from the government?
I think the ministry are very stretched. They do lots of things, and you know, we part of the collaboration must be with the ministry, and we continue to have dialogue with them. And we've been talking for 10 years about having a national secondary prevention register, and that's been part of the announcement. So you know, it's again slow train coming, but they're coming to the party there. I think one of the aspects that we haven't talked about is that there was a publication came out from Australia a couple of years ago. It was called Neglecting the Neglected. So the funding for rheumatic fever and rheumatic heart disease on a disease burden basis is right down the bottom. So it's a big disease numerically, you know, after TB and AIDS and infectious diseases, but actually the funding is just tiny, and so it is taking New Zealand and Australian and African researchers to try to really to renew the interest, which has been going on, but it's still small time compared to a lot of diseases funding.
And it's just so complex, because you've got all these complex science problems layered with all these really complex social and deprivation problems, and we're in such a unique place with such a huge challenge, really.
Do you feel though there is a focus from the Ministry of Health onto dealing with this disease?
Yes, there is, and I think we need a strong patient advocacy group, no pressure. But you know, that's been lacking as well. You know, you look at cancer, you have breast cancer, prostate cancer, there's advocates, big groups hounding, you know, trying to shame the government, trying to shame the ministry, and they're very vocal, and we haven't got that, and this needs to be part of the big collaboration going forward, I believe.
Thank you, Matt. I think.
Sorry, I was going to ask, what more would you like to see the ministry and the government doing for this?
Well, I think one of the areas that's been identified is the need for basic infrastructure, and we've talked probably for 20 years, different groups, about the need for a rheumatic fever register. It's quite a small group of patients and, you know, numerical numbers who've been diagnosed, and I think this would be a key tool to improve delivery of prophylaxis. But it could be extended to actually look at children who are even more vulnerable to rheumatic fever, and we could take a population approach to it.
And ideally that would include not only the New Zealand but also the Pacific Islands.
Yeah.
Michael, with that register in August, the Ministry of Health said there was a review underway. Have you heard how that review's been going?
I've heard pre-election, I think there was some mention that that was a likely strategy for the incoming government. But I don't know if anyone here has any other further advance on that. But it's actually a very cost-effective tool, because we've already heard how penicillin prophylaxis or treatment after you've been diagnosed with the case is the single most effective intervention that we have available at the moment. And there are some children falling through the cracks. So that would be a key piece of infrastructure. It's not the only thing to do, there are a number of other things as well. But we have met with, over the last few years at several key meetings, and put forward a series of recommendations to the government and they include actually having a plan would be a big start, an intervention plan, as well as a research plan to support that. And in some ways, Cure Kids are filling that void, in a sense, by prioritising a set of projects for research, which is hugely appreciated. But it needs a lot more than that. I mean, we've had some really good starts over the last 20 years. We've had a trans-Tasman vaccine collaboration that did a lot of good work to get started, but really it needs that next phase of moving forward, and I think Australia and New Zealand really have fantastic collaborative links already, and I think we could build on that to have a really strong trans-Tasman collaboration on this.
Recently, because a lot of the big Australian vaccine development labs have got a big boost in funding, and the New Zealand researchers working on candidates which are just as promising haven't had the same boost from our government. So Jessalyn hasn't complained about that, but I'll complain on your behalf. Are there any other questions, please?
Rugby world in New Zealand is a lot of Māori Pacific participants. So is there any kind of drive from the rugby union to drive rheumatic fevers from that perspective? I can imagine you're not the only rugby players had that as a disease in New Zealand.
No, there's not really a drive around that. Yeah, there's a handful of us. I think Robbie Fromans, it's his fault I carried on playing rugby because I used to watch him all the time. And then I found out he was, he had heart surgery as well, had the same thing, and I just followed in his footsteps. And Buxton Papali as well, he's another one, but there's not much say around the rugby environment, around rheumatic fever and whatnot. Yeah, I think especially rugby, obviously all the PI and Māori kids look up to those kids. Yeah. So I guess it's a great platform from a rugby point of view just to share my story. Yeah.
Matt, how's your mum now?
She's alright now. She's happy now. Relieved. But yeah, I think I've put her through the walls there. Since I was 13. So. I haven't helped her, and she'll probably have a heart attack soon. Far out, pushing her to the edge. Yeah.
We support the families going through heart surgery, and it's just so sad that a preventable disease facing heart surgery, and it's just so stressful for the whānau as well as the patient. A child having to face up to heart surgery. It's just awful.
Do you think that rheumatic fever and rheumatic heart disease it's never been a particularly high, it's never been a huge one. We've got some pretty sexy diseases out there. Is that because of who it affects?
I agree with Annika. If it was a Pākehā problem, it would be been abolished by now.
And I think the trouble is when you've got Māori and Pacific children, there's so many individualised behaviours that are blamed. If you look at the most recent awareness campaigns with mothers crying, probably like poor Matt's mum going, it's my fault, I didn't take my child to the doctor. But what we're finding working with whānau is they are taking children to the doctors. They're often not getting the antibiotics prescribed, they're not getting their throat swabbed, or they're asymptomatic and they don't have sore throats. So we've got this discourse of blame, particularly for mothers and whānau, which is then ignoring the more structural determinants of causation. And then when we see it, we go, well, that's the irresponsible parents. So, it's quite a wicked problem.
I'd also just like to mention that we're lucky enough to have here with us in the audience Professor Julian Payton and Lisa Wong, who have just received funding from the Tertiary Education Commission for Manaki Manawa, which is a new centre of research excellence, and their proposal was really based on equity and heart health. But that theme of really making sure that Māori and Pacifica heart health is attended to was central, and we're really hoping to work with the core in future to see what we can achieve together by combining our efforts to support research like this. Are there any other questions from the room? If not, what we have scheduled now is a series of one-on-one interviews, so I think we will say thank you to you all, but before we do that, I forgot at the beginning I was going to ask Shannon Lua to lead us in a karakia, so if it's not inappropriate to have a closing karakia without an opening karakia, Shannon, could I call on you now? Thank you.
Kia ora tātou. Te tuatahi mini atu kia koutou ko taumani o tēnei rā. Koutou rā, kia kids, tō ngā kaimahi, ngā kairangahau, I tatu mai nei I tēnei wā, no reira tēnei rā ka mini atu kia koutou. Atu I tērā, kia ino tātou, tērā strep. Kia whai kororia hono rei harihui kia koe I hoa o ngā mano. Tēnei mātou o korona I nei whakamohi te whakawhitai atu kia koe tēnei wā. No reira I hoa, tono mai o mana tanga ki tonu kia tātou katoa I rau I te tōni o tēnei whare. Kia ho mai kia tātou katoa, ki te taro, ki te ora, ki te kaha, ki te māramatanga o te rangi mai ki kia tātou I ngā wāna katoa. No reira I whā, te tumanako te pai te haere o ngā whakawhitiwhiti kōrero I whāna o tēnei kaupapa, tino whakahira o mātou nai te iwi Māori, me rātou E ngā whānau o te moana ni āki wā. O reira, tēnei rā, ka mihi atu kia koe I hoa, e te māngai ngāna hira pono I te tukotori tapu, whakaungia mai mātou te aoha noa, pai here te alu mātou ki te rangi Māori ki ni ke tātou ngā wā katoa, te māngai ngāna ki te tautoko kia tūturu kūma, aia te āki nei. Kia ora tātou.
Kia ora, Shannon, and a huge thank you to all of our researchers. And now we're going to enable an opportunity for some closer interviews. Thank you.